Hello everyone, I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare.
Our guest today is Dr. Robbie Bowers. Dr. Bowers is a sports medicine physician at Emory Sports Medicine Center. He attended Furman University in South Carolina, where he played Division I college baseball and majored in health and exercise science. He then attended graduate school at Auburn University, where he earned a Master of Education in Exercise Science and a PhD in Exercise Physiology. Following grad school, Dr. Bowers earned his medical degree from Philadelphia College of Osteopathic Medicine. He then completed his residency training in physical medicine and rehab at Emory, where he also served as chief resident. Subsequently, he completed a sports medicine fellowship at Emory as well. Currently, Dr. Bowers is director of the Emory Baseball Medicine Program, which is designed to treat baseball and throwing-related injuries to prevent further injury and enhance athlete performance. As a former Division I college athlete himself, he brings a unique understanding of sports-related injuries to his patients. He currently serves as team physician for the Atlanta Braves and the Georgia Tech baseball team. He's also the head team physician for the College Park Skyhawks, the G League affiliate of the Atlanta Hawks, and Woodward Academy. His specific clinical interests include baseball medicine and throwing athletes, sports-related musculoskeletal injuries, diagnostic musculoskeletal ultrasound, minimally invasive ultrasound-guided procedures, and treatments that involve using a patient's own cells and growth factors to stimulate natural healing of an injury. For avid listeners of the podcast, you know this is the world of orthobiologics, and that is what the majority of today's conversation is centered around, primarily PRP. We dive deep into all things PRP, starting with some basic definitions, indications, contraindications, mechanisms of action, and optimization and specific protocols. We really get into the weeds, but our hope is that you, the listener, will leave with a much better understanding of what PRP actually is in the context of musculoskeletal medicine. There is so much misinformation out there, and the debates among academics get to be quite ridiculous, particularly when people start speaking about things they don't actually understand. So maybe after this, you'll feel more comfortable dissecting and dismantling the poorly communicated science, at least. Considering his background and expertise, we do spend a good deal of time chatting about baseball medicine and some of the unique injuries and their management. Dr. Bowers is a leader in the field of baseball medicine and has been a great resource for me personally for some of the challenging cases, so I hope my fellow musculoskeletal practitioners will find some utility in that. We close with getting his perspective on the future of orthobiologics and the rapidly evolving field of musculoskeletal and sports medicine. So, without further delay, please enjoy this discussion with Dr. Robbie Bowers.
All right, Medicine Redefiners, we've got Dr. Robbie Bowers here with us. Robbie, how you doing today, man?
Pretty good. How are y'all?
We're doing well. Thank you so much for coming on to the show. I got to ask you first things first, though. Take us through that 2021 World Series experience. As a Braves fan, I mean, I remember watching it on my honeymoon, actually, just like 3 a.m. in the morning, pulling it up on my phone, and just celebrating. So yeah, take us through that.
Yeah, so I grew up in Atlanta too as a huge Braves fan, and so getting to even just start working with them is kind of a surreal experience. So it was in 2021 was my first year working with the team too, and obviously it was kind of a slow start to the season. They didn't go over 500 until August, and then things just started going in the right direction and getting to the playoffs and I mean, it's kind of a blur, but it was then, and I was there for the whole for the playoffs. I was there at every clinching game. So I got to be part of, we beat the Brewers in the divisional series, got to be part of, see everything. That was my first time being in the locker room, pro sports, was shooting champagne everywhere and stuff like that. It was cool. And then in LCS with the Dodgers, and then for the World Series, I actually wasn't supposed to travel with the team, and we had the possibility of winning the World Series. So I was like, you know what, guys, I'm coming. So I just went out there on my own, and it was, I mean, it's hard to put it into words. Obviously, I'm struggling with words. It was just, it was like the coolest thing, because not only is it with the team that I was working for and that I'd spent the season with, and you get to know guys, which is cool. It was just, that's the team that I remember when I was 12 years old and they win the World Series in '95, and I'm watching at home, and it was just, you're just so happy at that point, and just thinking back, and now I'm older, and I'm actually in the locker room with the team. It's like to think about that when you're this 12-year-old kid is just really really cool. And if you see, I mean, you can kind of see behind me a couple like the champagne bottles that you grab
Hmm.
from the locker room. So it honestly is hard to, like, put into words, but it was, and docs will work for pro sports teams for their entire career and never get to be a part of a championship. Literally, my first year working with a pro sports team, they win they win a World Series, and I get a World Series ring, not only for just a random pro sports team, but for, like, the team for me growing up. It's just, like, really cool. And I think still being in Atlanta and having family and stuff and asking about, like, getting to see the ring and all that, it's like it's really really cool. And so I've been, more than blessed early in my career to get really awesome opportunities. And so before it's my last year in my 30s. I'm 39, and so before I'm 40, to have these types of experience in sports medicine is, like, pretty cool.
Yeah, no, absolutely. I mean, me and my family always talk about the 90s with the 14 in a
Yeah.
row titles, and then but unable to capture that World Series finally happened, and now it seems like at least hopefully it's a dynasty in the making. Hopefully with the amount of players and pitching
Yeah,
that we
I
have,
hope
so
so. I
excited
think
to.
things are for sure looking up, and I think I'm excited about this season too.
For sure. So, Dr. Bowers, you are a PM&R physician, just like Ultimash and I. You're obviously in sports medicine as well. Take us a little bit through your journey, how you kind of thought about what you wanted to do later in life, and kind of your training as well.
Yeah, so I played college baseball at Furman University in South Carolina, and at that point, I didn't know going into college. I didn't know what I wanted to do, and so I just decided to major what I found interesting, which was exercise science. And so I played a sport. I major in exercise science, and still at that point, you can't really do anything out of undergrad with an exercise science degree. I mean, you can do something with it, but nothing of a ton of substance. So I decided I wanted to go to graduate school, and the initial thought was, hey, I'm gonna get my PhD in exercise physiology and be a college professor. And I think just along the course of graduate school, I just kind of felt like full time academia wasn't really for me. And I was doing more clinical exercise physiology research with metabolism and weight loss and things like that. And so we were doing a lot of medical based things in the lab, and we had to have a physician around for most of it. And I just got talking to him, and he was part of a residency program, and he would bring med students and residents with him. And so that's how I kind of got interested in the medical side of things. And so I decided, I'm gonna apply to med school and see how it goes. And if after I finish my PhD, I can either go that route. So I actually had, I could either go to medical school, or I had a postdoc lined up at Vanderbilt Medical Center to do more kind of like I was doing more of then, like, metabolism and weight loss and things like that, which is more of endocrine. And so I decided to go the med school route. And I think once I got into med school, it really was a decision of, do I want to continue some of the things I was doing more with my PhD, or I still had this kind of inner washed up athlete in me that, was just always this sports obsessed person. And I think just long term, as far as the patients that I wanted to be involved with and take care of, sports medicine just seemed better than going down like the endocrine route, which is going to be, and anesthesiology had a lot of physiology with it, so that interests me as well. But I think just from a general patient population standpoint, what you're going to be doing on a daily basis, just sports medicine seemed better for me. I really, I loved my orthopedic surgery rotation in med school, but I just go in the orthopedic surgery route and kind of lifestyle, and the way things had been like in residency and things like that was just not the way I wanted to go. And I was newly married, and we were going to have kids and stuff like that. So I started looking into kind of the non-operative approaches to sports medicine, and I just found PM&R. I did some early PM&R rotations, and I found PM&R to be the most appealing as far as just the breadth and the amount of musculoskeletal training you get in residency versus going the primary care route. So that's kind of how I got. That's a brief rundown of how I kind of focused on PM&R, and I always knew that I wanted to do sports medicine. So when I started PM&R residency, I always knew I was going to go the sports route. I'm still kind of a endocrine and physiology nerd and really enjoy that stuff. And in PM&R, I think people don't realize just how much physiology plays into spinal cord injury and just changes in human physiology with a spinal cord injury. And so spinal cord injury actually really interested me, but nothing to like take me off of the route of going sports. And so it's kind of a brief rundown of my training and kind of where I've been and how I made the decision to kind of go the route where I ended up going.
What position did you play in college?
I was kind of more of like a utility player, and so I played third base, some outfield. When I first started, played a little bit of second base, and so moved around a little bit.
Any injuries in your own athletic career?
Yeah, my arm killed me all the time. Like it just that's and I think that's just part of being a baseball player most of the time. Like your arm feels terrible a lot.
Hmm.
And it's just like it's so funny. Like I had just like rip roaring biceps tendinopathy like my entire time playing to where the point like you can't even do biceps curls like in the gym. And it's so funny since I quit playing baseball, like literally never had that ever again. So it's totally just based on volume of throwing. And so I had a number of throwing injuries and was injured a fair amount. Nothing like catastrophic that I needed surgery for, but I did need surgery after I finished playing, and so my joint was just loose, and I subluxed one time afterwards, just in the gym. My joint was loose from my throwing, so I had to have my joint tightened up and a labral repair and everything afterwards, and that definitely will. If I try to throw now, it definitely impacts kind of how I can do now versus how I did before. But as far as I'm trying to think, I had a spondylolysis when I was in high school playing football, and so stress fracture in your lumbar spine, and had to take some time off for that. But as far as major injuries, I'm trying to think. I do not believe that I had like a major one. Just kind of these ones that'll set you out for a couple weeks here and there, but no major surgeries until after I finish playing.
No, that's good. It's interesting because I think a lot of us folks who are in sports medicine, and I was recently having a conversation with one of the third years who's considering PM&R versus family med to go non-op sports med, and was telling me his story, just a lot of injuries, also played college basketball, trying to get back. And I was telling him how, um, you know, I share his story and I've heard his story, and yours is somewhat unique in the sense that you went that exercise physiology route and you really developed a deeper understanding of metabolism, physiology, which reminds me, we had a lecture when I was in residency where I think it was a pediatric orthopedic surgeon who came in and talked about how, orthopedics are the experts of anatomy, and therefore physiatrists have to be the expert of physiology. And that really stuck with me because I think it largely holds true, right? When we talk about biomechanics and gait and all that stuff, there's really nobody else who's better equipped to address that and analyze that than our field. So I do love that. What point in your training did you develop an affinity towards orthobiologics?
I think it just kind of came with the territory of training at Emory, just because Ken Mountner's here and he's been involved in it from the get-go. And I think from a residency standpoint, we get a lot of exposure to orthobiologics in residency that I don't think you necessarily get at other programs just because of the volume he does. And we have a dedicated rotation with him in residency. And so that is probably really where the interest and influence came in to get involved with that, because I just think he's kind of one of the people that's been there from the get go, and we train with him, and so you get kind of a deeper understanding of those treatments, and you see some of the more cutting edge stuff like in residency in 2015. You're seeing adipose and BMAC and not, and then you're also seeing a lot of PRP too, and having discussions about these things, and kind of just starting that to pique your interest. Okay, what are these treatments and what do we use them for, and are they better for people than other treatments? And so that's really where that interest started. And I think it just comes with the territory of training here. If you're going to be interested in sports medicine, that's a big component of the training that we get here.
Absolutely. I love that. And I think, as we were talking about offline, my hope is to be able to at least take one aspect of orthobiologics. Some people still refer to it as regenerative medicine. I think, you know, and I know, and Dr. Malanga was on here before, talk about how we don't refer to it as that, and people can look back at that episode and learn about why. And my hope is that we can really dissect and go deep into PRP, because I think there are still so many misconceptions, and it can be somewhat of a polarizing topic, particularly with the non-op versus operative guys, right? These battles that continue, and we've touched on it before, but I'd love to kind of hear your definition. Is how do you communicate with patients when they have no idea what orthobiologics are, and how do you explain to them what PRP is and what the role is in the body?
Yeah. So I will say, just leading off between PRP and the other orthobiologics, and like you mentioned, when we talk about, we go back and I'm sure um, Dr. Malanga, um, he laid it out much more articulately than I am. It's not regenerative medicine. We're not trying to regenerate tissues, and so it's a bit of a misnomer. But the field name still holds to an extent, just because sometimes that's what people know. But I will lead off and say that, and we're trying to refer more as the field of orthobiologics as opposed to the field of regenerative medicine. And I do kind of cringe a little bit if I have to say regenerative medicine, because it's not. I mean, we're kind of leading people astray by using that. So I try to I try to refer to it as orthobiologics. And then if we look at the field of orthobiologics, and platelet-rich plasma is one of those treatments. And then on the more kind of mesenchymal stromal cells, medicinal signaling cell side, what some will still refer to as stem cell injections with adipose and bone marrow aspirate. The way that I approach it with patients is that I always try to kind of lead them in direction of PRP first, unless for some reason they're just like hell bent on having one of these other treatments. Just I think from a cost standpoint, and then if you look at the data, there isn't any significant compelling data to me, at least yet, that you have significantly better outcomes with bone marrow or adipose for various conditions. And I think we can look at knee osteoarthritis as one thing. There may be some data showing that for more severe knee osteoarthritis that you can have some better outcomes with bone marrow as opposed to PRP. But I think if you look at the totality of the data for all different pathologies, there's just not enough data for me to say, okay, I'm going to bypass PRP to go to these other treatments. While they may be a little bit more cellularly robust than PRP is, I think the data doesn't bear out that outcomes are significantly better. And we can always have those in our back pocket if we need to. And we may get data along the way that says, there's some thought with adipose that, hey, maybe adipose for a tendon can create more of like a scaffold for tendon healing. And that's more of a theoretical thing still right now. I don't think we have data for adipose for tendon. And that's something that I look forward to in the future, is getting data for adipose and tendon pathology. But the way that I do approach it, I think that it's more important to have kind of a detailed conversation of PRP if we're going to go down this path, is that I always try to lead people down the path of PRP first for both a data reason and a cost reason as well.
Mm-hmm. So I imagine, again, in my practice, patients come to me and they've never even heard of it, right? But again, if you're
Right.
going to Emory Sports Medicine, you probably are being referred by somebody. And again, as you mentioned, it's just,
Yeah.
within the. So, what are patients, if you ever saw somebody who has never heard of it?
Yeah.
What's your first
Yeah.
conversation like for PRP
So
stuff?
I see patients all the time that have never heard of
Oh,
it.
do you?
Like plenty of people come to me. I mean, we get some patients that are referred specifically for it, but we have plenty of people that I have the orthobiologic conversation with that have never heard about it before.
Hmm.
And I try to keep it as simple as we can. And I talk with them about kind of the role of corticosteroid, or I use a lot of Toradol in practice too, as far as just anti-inflammatory and making pain better. And then what else can we do, whether that's physical therapy, to try to stimulate some healing to get it better. And then I talk about, okay, if we're going to do something active in the office to try to stimulate healing, these are where these treatments come in. And so I'll first talk about platelet-rich plasma. And I always tell them, okay, we're trying to stimulate healing. What platelets do is, so say you get a cut, platelets help to heal that cut. And so I tell them platelets are the healing cells in the blood. So if we can take out some of your blood and spin it down and concentrate the platelets, and then use ultrasound to directly inject it into the area where you have injury or pathology, we're going to try to stimulate healing. And so that's I just try to keep it as simple as that. To just let them know it's a healing injection, but that the healing process takes time. And so, unlike something like corticosteroid, you're not going to feel better in a few days. This is going to take time. It may take 6, 8, 10 weeks for you to really start to feel better. And I think it is just about managing expectations, trying to explain to them what are these treatments? Are we trying to just affect pain, or are we trying to affect healing? And that they just have to be patient with it. And so I think trying to get as much patient education in as you can while also keeping it on a level where you're not getting into the weeds too much is important.
Yeah, I love that. And I think that when we're talking to our colleagues, one of the things that the reason it gets contested and debated amongst academics, I think, is because, or the two main things that I hear about, there's no standardization, right? And there's too much variability, which kind of goes hand in hand. And the definitions can be somewhat loose. And we touched on previously with Dr. Malanga of like that not all PRP is created equal. And you mentioned Ken Mountner, and I think him and Dr. Malanga and a couple other people were really the first ones to propose this PLRA system. Is that still the most up-to-date way that we're referring to it when we're talking about the data, or is there a better system for standardization that you guys are familiar with?
Yeah, I think that's still, for the most part, the best way. And that is talking about what's the platelet concentration. Is it leukocyte rich? Is it leukocyte poor? Um, are there any red blood cells? And so, if you want just a standardized way um, to talk about PRP, I still think that's for the most part the best way. I don't think there's been really an extrapolation proposing other ways to do it. But really, to be honest, it's not that we necessarily has to have a classification system. I just think for our literature, we have to be able to explain what we are injecting. So, what is a platelet concentration? Is it leukocyte rich or is it leukocyte poor? For the most part, we're removing the red blood cells. So, I think that point to an extent is moot. I'm not sure. So, if you look at the classification system back from 2015, there's also a header for is it activated or not. So, do you use an activator to kind of get the platelets working? And I honestly don't see that much people using that in practice anymore. Some might and may call me on it, but they're different activators. Either you can treat the PRP with, or I know you can put it under like a fluorescent light to try to activate it. I'm not sure what the data is to support that, and I don't see very many people doing it anymore. And so I think it really comes down to, if we want to simplify things, what is the platelet concentration compared to baseline? Either you can say it in how many billions of platelets there are. Like baseline, I believe it's 150 to 300 million platelets at baseline per blood sample. And when you make PRP, for to be true PRP, you're kind of 1.5 billion platelets. And so you can say it like that. Or I think the easier way to explain it is times baseline. So how many times baseline is your platelet concentration? And I think that, or thought at least at this point, are some of these higher platelet concentration systems that we can use to make it, 4 to 7, 8, 9 times baseline is probably the most ideal. And so I think in the literature, we just need to do a better job of, and I think anyone who publishes anything in PRP now needs to say, this is the platelet concentration, or at least explain in their discussion with the PRP concentrating system that they use that I mean, because most of these concentrating systems, they have data saying what the normal platelet concentration is with using them. And so if you look at something like MSite pure PRP that we use, it's like 5 to 7 times baseline. And on the other hand, if you look at Arthrex Angel, which is more of an ACP, which is like barely above baseline concentrations, you can't call both of those PRP. And so I think that's where you get into trouble in the literature, is some of these papers are say PRP in the title, and PRP does not work, and you look and it uses this platelet concentrating system, and you look deeper into it and it's 1.5 times baseline, and that's not really PRP based on the definition, or based on what we, at least to this point, know works better from a PRP standpoint, which is a higher concentration.
So let's talk a little bit more about the first two aspects, right? The platelets and the leukocytes. In your
Yeah.
experience, for staying on the platelet count, what are maybe what does the data say, and also in your experience, what are the optimal platelet concentrations for? Maybe we could break it out into articular pathology, That could be arthritis, that could be more labral stuff, right? And also more for tendinopathy, which is probably what's much more common for. What do you use? What does the data say?
Yeah. So we use the MSite PRP system, which I just mentioned, which does, reliably create a higher platelet concentration beyond baseline, about 5 to 6 times baseline is what we usually see. I think Magellan has a system that I know off the top of my head, so I'm sure there are other ones out there. And Harvest has one too. And if you look out in the market, I mean, there's 35, 40 different platelet concentrating systems. So how do you know which one to choose, especially if you're new to this field? And I think that's a big hurdle that we have to get over, because some of them, like I mentioned, and I don't want to throw, I probably already mentioned one, but I don't want to throw companies under the bus, but just don't have a concentration that is high enough to really be PRP. And I think you need to look at the amount of blood that's being drawn. So if you have a system that is, you're only drawing 10 cc's or 15 cc's of blood and using a single spin, you're not going to get the platelet concentrations that are truly PRP. It needs to be a higher volume of blood. For me, where I've gone now is I do a 60 cc kit or draw for every pathology, whether it's a tendon or a joint, just to get that larger volume of blood. And the system does a double spin, and so you concentrate the platelets down better. So a higher volume of blood with a double spin system is going to give you a higher platelet concentration in your final product that you get. So I think that's number one from a platelet concentration standpoint. And so I use that MSite system across the board. So it's going to have that, kind of standardized. And there's white papers in the literature and third parties that have done these examinations to look at platelet concentrations for these systems that you can find online. But most of the higher concentration products or systems that are out there is going to give you a product that's anywhere from 4 times to 9 times baseline platelet concentration. And I think any of those systems, for people that aren't just processing their own blood with their own system, if you're going to buy a system, I think you have to look for one of those higher concentration ones that is going to be a larger volume of blood drawn, at least 30 cc's, in my opinion, 30 to 60 cc's, and it's going to have a double spin, is going to give you the platelet concentration that you're looking for. So that's what I use, and I use the same for joint and for tendon. And you've also brought up the issue of leukocytes or neutrophils, which are the white blood cells. And there's some data out there that says, hey, maybe leukocyte rich is better for tendon pathology. But in my opinion, I'm not convinced that the extra pain that comes along with adding leukocytes to the injection, so the juice isn't really worth the squeeze, in my opinion. So I'm not convinced that leukocyte rich leads to better outcomes in tendon pathology. And there is some data out there that says that leukocyte poor may lead to better tendon proliferation than leukocyte rich does. So you're already stimulating the healing response and some inflammation in the healing cascade by using PRP. And then by adding leukocytes to it, adding additional inflammation. Is that extra pain worth it for the patient? And does it really lead to better outcomes? And there's some data showing that it doesn't. And so in my opinion, I use a leukocyte poor PRP product with appropriate platelet concentrations for all the pathologies that I treat. I don't change it. Now, in the future, that 100% can be proven wrong. The way this field is going is figuring out ideal platelet concentrations and preparations for different pathology. And I think that we'll get to this point. I just don't think that we're there yet. So in my opinion, and I know in, the people that I trained under, specifically Ken Outner, that's who I learned from. And he's of the same opinion that a leukocyte poor product with appropriate platelet concentrations at this point is kind of the most appropriate and what we feel like works the best based on the literature and kind of our own clinical knowledge.
Yeah, the first time I heard that was from Chris Cherian, one of your previous fellows, right? Chris and I were talking about this maybe 2 years ago, and he told me that that's what you guys are doing, and it didn't quite make sense to me, particularly because when I look at the data, I think to date probably the best papers by Fitzpatrick, I think maybe in 2018,
Yeah.
where he showed that, for glute med and lateral epicondylosis. And even AMSSM had a position paper on regenerative medicine, quote unquote, last year, talking about and showing kind of the data for different pathologies. And even within that, leukocyte rich. And so the challenge becomes, when you're having these conversations at society meetings, you do this far more than I ever do. And, people will say, well, the data suggests leukocyte rich is better for tendon pathology. That being said, you're saying more and more. I guess the question becomes when somebody has chronic pathology, the argument that's been made to me has that, hey, look, that inflammatory response, which we know is the first phase of healing, is going to be beneficial for more chronic because we're not seeing an itis and you're almost trying to recreate that. Will some pain come with this? Absolutely. But that's part of the healing process. Any thoughts to that part of it?
Yeah. So I think you definitely don't want that in a joint for sure, because that extra inflammation can actually help further break down cartilage. So I think for a joint, 100% leukocyte poor. I think where there could be an argument made is going to be for a tendon. Like I mentioned, there's some data in the literature that maybe a leukocyte poor can lead to better tendon proliferation. And when we do PRP, when you're needling the tendon, when you're injecting the PRP, you're still you're stimulating the healing cascade. In the first phase of the healing process, we look at, you know, the inflammation phase, the remodeling phase, the proliferation phase. That first phase of the healing cascade, regardless whether there's leukocytes or no leukocytes, is the inflammatory phase. So you're inducing some inflammation to start that healing cascade. And so I think the question is more, is that extra inflammation from the leukocytes, is that worth it? And will that make things significantly better? So my thought would be, yeah, for these papers where they're using leukocyte rich, the Fitzpatrick paper, James Fitzpatrick, are like great papers, level 1 data for glute tendinopathy. I think we're really just, focusing in on that, then you would use a leukocyte rich. But I think the question would be, if you were to then look at a leukocyte rich versus a leukocyte poor, would outcomes be different between the two? They just happen to use a leukocyte rich in that situation. And so that would kind of be my argument towards it. And for all of our tendinopathies, we've used leukocyte poor over the years and had good outcomes. I mean, say good outcomes from an anecdotal kind of clinical standpoint. So that would be my thought. We're already going to get some inflammation by inducing the healing cascade. And does the extra inflammation from leukocytes or neutrophils, does it help, or does it possibly hurt the overall process? And I think that remains to be seen.
Gotcha. Yeah, so that makes sense, at least, right? From an initial putting the needle in, stimulating that inflammation. But just for the audience, can you explain the difference between the inflammation from a platelet standpoint and then the leukocyte standpoint? Are they bringing out different inflammatory markers, growth factors? What exactly is the difference between the two?
I mean, we're really getting into the weeds now. So, I think of the inflammation that is being caused, it is, I would just think of it, if we're being simplistic, and just think of it, because there's so many different growth factors and cytokines and
Right.
stuff that are involved in these. So it's hard to, I wouldn't necessarily like get way down deep in that. I would just say that it's similar inflammation. It's just extra with the leukocytes, and does the extra that's going to bring some extra pain associated with it with the procedure, is it worth it? And so that's the way that I think about it. And I think you would probably need someone a little bit more versed in the cellular stuff to probably have that conversation with than me. So we're starting to get, even I think, as someone that understands orthobiologics pretty well, maybe a little bit over my head, above my pay
No,
grade.
no. Well, I think the other part of it is incredibly complex, and it's still developing. Yeah, PRP's been around for 30, 40 years, and in different fields of medicine and veterinary medicine probably started there, and then dentistry, I think, and stuff, that kind of stuff. But we're still understanding how it responds within humans, and also when it gets to the human body in vivo, how does it interact with environment? And I think that's kind of the challenge piece of it. But you also mentioned, some of the data with leukocyte poor, but also how the art of it from your perspective, and just mechanistically how joints and tendons are different structures, and how that might respond. And I think that's another challenge of it. We spent some time in the beginning talking about the data, and I alluded to the fact that it can be very contentious, right? I remember not too long ago, I was on LinkedIn. I think Chris Centeno put a post about this where there was a paper, I want to say it was an AJSM or one of the arthroscopy journals, which showed that PRP was not better than saline. And I couldn't seem to find the paper. Maybe you know what I'm talking about. And one of the issues with the way that they had the selection criteria is they had like an impact factor above 3.5, only studies in that, which was frustrating because all of us know that, yeah, at the superficial level, that suggests that maybe it's a more prominent journal or maybe better data, but that's not necessarily good data, right? I mean, that's not necessarily suggestive that this is a quality study that's going to be done. And I think that that's another part that becomes really, really challenging. You're on social media, so you know this better than a lot of people, is that, people also have a specific bias, and then they look for the studies to help support that bias. And we talk about this all the time. It's like, what do you want to believe? Like, tell me what you want to believe, and I will find you multiple studies to support whatever your belief is.
Yeah.
And the challenge for me really becomes my cousin, who is an orthopedic surgeon trained in the Philly area. Now it's on the West Coast. We were having this conversation. We're talking about PRP for a family member. And I was like, look, she's got moderate OA, and we should go to PRP if steroids haven't helped. This is causing debilitated function. And we were just going back and forth. And I don't know if you figured out a better way to communicate, because I think that's one of the most important things that both of us could do, right? Is what's your approach? Help me communicate better, Dr. Bowers.
Oh man, this this is tough, and so like you mentioned, there's always implicit bias, and you can find literature to support your viewpoint. You can write a review paper, to support your viewpoint if you want to. And I think that one paper you're talking about, I can't remember the specific topic, but I think all of us, it may have been on data for PRP for tendinopathies, and
Okay.
it left out like the landmark initial paper by Alan Mishra on PRP working for tennis elbow for lateral epicondylopathy. And so there are all these papers that we looked at that, and it was basically saying PRP didn't work for tendinopathy, and we were all saying, whoa, wait, what about all these papers that show that it works that you didn't include in your review? And they just had these kind of nebulous cutoff factors for what was included and not, like you mentioned, the impact factor and those sorts of things. And so those certainly are out there. And I think there was the Bennell paper in JAMA that came out last year. And so Journal of the American Medical Association, like big time journal, publishes a paper on, and it was a randomized controlled trial. It was like brilliantly designed, except for the fact that they called it PRP and it wasn't PRP. They used, I think, I can't remember, maybe it was one of the Arthrex systems that's more of an ACP, autologous conditioned plasma, which is really of just a kind of a whole blood concentrate, doesn't have appropriate platelet concentrations. So you can say ACP doesn't work for knee OA versus saline in that situation, but you can't say PRP doesn't work. And people ran with that and said, oh, look at this great level 1 trial that says PRP doesn't work for knee OA. Well, great if they'd use PRP. And so I think that is where kind of this homogeneous data comes in. It's everything that's called PRP is certainly not PRP. And I think if we're going to communicate something, I think number one, that has to be what we communicate, especially if it's to other physicians. It's like to say, okay, so you're telling me at this point that for this pathology, PRP does not work. And I have the opposite approach that PRP does work. Can you support this with literature and show me? And so maybe they pull up that paper and you say, okay, look, this is why this paper doesn't really hold water in this situation, and where we have 30 or approaching 30 other level 1 trials that show that PRP works for moderate knee osteoarthritis. You can pull one of those, and we have a meta-analysis that shows that PRP works better for knee osteoarthritis compared to corticosteroid, compared to saline, compared to hyaluronic acid. Like, I think the argument that PRP is not an appropriate step for someone with mild to moderate OA is kind of silly at this point.
Yeah, I couldn't agree more. And I think that if there's one call to action, kind of what we talked about in the beginning, is let's clearly define whatever form of quote unquote PRP you're using. Because otherwise, it's like putting a study out there that shows that beta blockers reduce morbidity from heart failure or something and just saying we used beta blocker, right?
Right.
That's not very helpful and actionable to change somebody's management. So hopefully people get that message across. I do want to
And
take the flip side. Sorry, go ahead.
yeah, I was going to say that that journals also, I mean, this is where bias in journals probably comes across too. And BJSM had this bias, like previous editor, like just was a detractor of orthobiologics and would only kind of publish papers that would, say they don't work. And I know that people have had issues with that. He's no longer the editor there, but I think these journals have to get orthobiologic experts to review these papers. So obviously in that JAMA paper, they did not have anyone that's like well versed in orthobiologics, or else they would have been like, wait a second, here's this like there's been no discussion in this entire paper about platelet concentrations at all. They just said we used this PRP system and it doesn't work. And there was no discussion of it in the paper. And so how does that get through peer review for like an orthobiologic based paper? I just don't understand. And so eh, there's got to be some sort of better process. And one thing that I think is great, so the Biologics Association, uh, which is an organization which is more collaborative between the orthopedic surgery side and kind of the non-surgical orthopedic musculoskeletal medicine side, and has orthopedic surgeons that are using orthobiologics and interested in figuring out the data and how we can use these not just as a surgical augment but also in non-operative practice. And I think associations like that where it's more collaborative are going to be really important for this moving forward, instead of like our specialty on the non-surgical side operating in a silo without orthopedic surgical side as well. And so we just have to try to get out of our echo chambers so that we can learn from each other for sure. But sorry, I cut you off.
No, no, no. I love that. I'm glad you brought up the Biologic Association. I only learned about them last year at some point, and I think for my medical students or just fellow trainees, well, I guess I'm not a trainee anymore, but for the trainees, yeah, I think it's free to join. And they have these summits that they record them, so you can go back and reference, and like all the experts, world-renowned experts that you mentioned, are on there giving quick talks. I know Dr. Borgstein has some great lectures. Dr. Matner's on there too, and a lot of other people. I do wanna play devil's advocate, or take the other side of the argument, at least from a non-surgical standpoint. You also have people who will say, okay, look, the data is robust for PRP if you're looking at the right and you're looking at it through the right lens, and therefore we should not be doing anything else. You and I have had many conversations about this offline, where they say, nope, corticosteroids, right? That initial paper in 2017, also in JAMA, I think, which showed the cartilage loss and stuff. So there's really no role for corticosteroid. If you're doing this, you're causing harm. If you're using lidocaine and bupivacaine, you're causing harm. And it's so incredibly challenging, because for me, it's when I have this patient who can't rub two pennies together in front of me and can't pick up their child, can't walk, and they're just debilitated and absolutely cannot afford even $500 of PRP, not considering the fact that the cost is variable amongst different practices. It's what am I supposed to do for that patient? And so, what are your thoughts about that aspect of it? I'd love to hear your experience with Toradol as well.
Yep.
Please comment on that.
Yeah. So I see way more of those patients than I see orthobiologic patients coming in to for PRP. Like way more of my practice is these people that, we're not going to have an orthobiologic discussion at all because it's just simply we can't do it. And that's a shame in the healthcare system. That something that I think can definitely help this person is maybe is healthier for them in the long run. I can't do because insurance won't cover it. So I would go to PRP for so many more of my patients, but I just don't have that option. And I think for something like a knee arthritis patient where we have robust data, or glute tendinopathy or tennis elbow, and these things that do cause pain that affect people's ability to live lives the way they want to live, that I can't do those things because insurance won't cover it. And I know that's nothing I'm going to solve, but it just is a frustration for sure. Um, Now, so let's say that we're going to focus on knee arthritis at this point. So this patient comes in and you say they're like very debilitated from a knee OA flare, and there are others out there that are so staunchly against corticosteroids and using them because you're gonna damage the joint. So yes, and there's a paper that came out last year that showed there's a risk for rapid deterioration of hip osteoarthritis with just a single corticosteroid injection, which is kind of eye-opening. So I think you just realize that you have to be judicious with it, but they still definitely play a role in certain situations. Um, so you have a knee osteoarthritis flare. We want to try to get the pain better so we can get them into some physical therapy and see if we can't get them better that way. So I think as a single injection, even though we do have some data showing that it can be harmful, I think as a single injection, it's something that definitely is still in my back pocket that I use frequently. I'm of the thought process that I'm just not going to repeat these frequently. So you hear some patients that are still coming in, getting multiple injections over the course of a year with with 80 milligrams of steroid or like Depomedrol or triamcinolone. So those are the things that should be removed from practice. Like there's no reason people should be getting 80 milligrams of steroid in a joint or in a subacromial space at one time. We have data showing for say for triamcinolone that 80 milligrams clearly is not better than 40 milligrams. And with increasing dose, you increase chondrotoxicity. And so if you increase the dose of steroid and then combine it with bupivacaine, which is significantly chondrotoxic if you compare that to ropivacaine. If you're doing those things, you're just kind of spitting. You just haven't looked at the data. Like you're just you. There's no reason to be doing that anymore, and I get kind of worked up about it. So for me, like when I use a steroid, I use a half cc. I use 2 milligrams of dexamethasone. Dexamethasone is shown to be the least chondrotoxic, had the least effect on local MSCs, and so I use some dexamethasone. I use ropivacaine and I use saline in a mixture. So I'll do like 2 or 3 cc's of saline, 2 or 3 of ropivacaine, and a half cc of dexamethasone. And in my clinical experience, that's been no different than what I saw in residency and before, where you use higher doses. People still will come back in 3 months and say they want another injection, and I'm not going to give them to them at 3 months because I think those days also should be gone where you're just blasting steroid every 3 months. And so I think yes, there's still a place for corticosteroid for sure, and it can definitely help people. And I see it still help people, and people come back and say, "Oh my gosh, it was a miracle. My pain went away. I got into therapy. I'm doing so much better." And I'm perfectly happy with that, and don't feel like I've robbed Peter to pay Paul, so to speak. I don't feel like I've damaged them by doing one steroid injection. I think it's just have to be judicious in repeating them in the future, and you have to know the literature that and I wonder if even less than the 2 milligrams of dexamethasone I used is even less still help people, and it may. I mean, we could start talking about like nanograms of steroid. Does that still help? So I think it's just knowing the literature that we shouldn't be using these high doses because they're not better. They've not been demonstrated to be better. And then also knowing the local anesthetic literature, we know that combination of corticosteroid and local anesthetic together is more chondrotoxic than either of them alone. And so then that we're going to combine them. So what are the least chondrotoxic of these medicines, and how can we use the lowest dose possible? And so we know on the local anesthetic side that ropivacaine by far is the least toxic of the local anesthetics. And so if you're going to inject that into a joint, you should use ropivacaine along with the lower dose of steroid. And so that's the way I approach it. That's the way what I think the literature bears out at this point. And I think it's just knowing that, especially for those of us that are going to do high volumes of injections in our clinics, is understanding that literature. So that is on the corticosteroid side. Now, the other argument to make is for ketorolac, which is trade name Toradol, which is a non-steroidal anti-inflammatory. And if you look at the literature and if we're still going to focus on like hip and knee osteoarthritis, if you look at the literature for the studies that have been done that have compared directly corticosteroid and ketorolac injections for knee or hip osteoarthritis, outcomes are the same. So outcomes are not different between corticosteroid and ketorolac. And so, say this same patient comes in, they have an acute knee OA flare of some moderate knee osteoarthritis. Should you use ketorolac instead of corticosteroid? And why would you do that? Well, number one, outcomes seem to be the same. Number two, ketorolac is a cheaper medicine than corticosteroid is, so it can save healthcare dollars. And number three, there is no data in the literature that shows that, well, I won't say no. There's one basic science paper that shows that ketorolac could have some chondrotoxicity, but literally every other paper that's been done has shown that it does not have chondrotoxicity. So take that data as you will. So it seems it has if we're being safe, we'll say it has less, if any, chondrotoxicity uh, as compared to corticosteroid. It's cheaper and you have the same outcome. So my argument would be for this neo A flare patient, you should try Toradol first. As long as the patient can have NSAIDs. Obviously, in a patient that has contraindications to NSAIDs and any other condition, you're not going to use it while doing it locally. That as much isn't going to get into their bloodstream. I still wouldn't use it. I still use steroid in that situation if they can't have NSAIDs, oral NSAIDs otherwise. So I think that is more of a thought, and it's just it really is interesting how few people use Toradol in these situations for these localized joint injections and localized musculoskeletal injections, because you would think that the fact that it's cheaper and covered by insurance and has the same outcomes, that more people would use it and be aware of that data, but just people aren't. And so in a lot of these situations, and we see this also for subacromial injections that people do all the time too. There's some data that shows ketorolac may actually be better for subacromial injections than corticosteroid is. And so I think that is also a very significant consideration, is to use ketorolac in these situations as opposed to corticosteroid.
Yeah, what's interesting about that, you mentioned about the bupivacaine and some of the corticosteroids. Bupivacaine is a lot cheaper than ropivacaine, so that's definitely one argument why people might use
That,
it.
yes.
Yeah, and but on that thread though, I was interested to find out that ketorolac actually is cheaper because I thought just from a practice standpoint and from a bottom line standpoint, people that might be one of the reasons. Now, what's your interval or threshold? I mean, is this something you feel more comfortable using every 3 months or so, or is the same logic applied that you're trying to space this out as much as possible?
Yeah, I mean, there's still local anesthetic involved. I still don't want to be injecting someone's joint every 3 months. And I tell all my patients that, I said, if we're in a pinch, you can come back in 3 months and we can do it again. But I don't love doing it. I think really the situation where I'm okay with doing it, if people have end stage, like severe, really bad arthritis, and these injections are still helping them to where they can function and live their life, and they either don't want to have joint replacement, they're not appropriate for joint replacement, whether it's that's from a comorbidity standpoint or a weight standpoint, and I'm not as concerned about like their OA progressing, it's already in stage, then I'm more apt to still do that, since it still seems to be helping them and it's something easy that we can do. In other situations, and more of like a moderate OA, mild to moderate, I'm just not going to do it. We're going to have the discussion about other things that we could possibly do, and this isn't necessarily part of the conversation, but there is some data for prolotherapy for knee arthritis, and so maybe we can try something like prolotherapy and see if that helps them as opposed to doing repetitive injections with steroid or with Toradol. And then this is where hyaluronic acid comes in too. But we know from the data that PRP is kind of routinely outperformed hyaluronic acid. But for some people, and certainly for Medicare patients, Medicare covers hyaluronic acid is a healthy injection for the joint. So we'll kind of go to hyaluronic acid after that. There is some data for I'm not sure about for knees, but actually for CMCOA, that combining ketorolac with hyaluronic acid is better than hyaluronic acid alone. So for a lot of my patients with OA, we're going to do hyaluronic acid. I combine ketorolac with that to give them some improvement on the front end, because we know hyaluronic acid takes about 4 to 5 weeks to really start working and exert effects. And so for someone that has a knee OA flare where we're going to do hyaluronic acid, I still want them to have some pain relief on the front end. And so I'll combine ketorolac with that. And so there may be some better outcomes with combination ketorolac HA versus HA alone. And so that's where, again, like your clinical experience, the literature, and kind of the art of medicine comes in. You have to combine all of those things together to find the most appropriate treatment for that patient, because sometimes orthobiologics just aren't an option for us because of the insurance coverage issue. And I'm not going to have that. That's where I'm never going to sell anyone on orthobiologics. Like I'm not going to sell them on it to convince them they need to do it where they're going to have to like take out a loan to pay for these things. Like I'm never going to do that. Like we're going to make that decision together, and if they're comfortable with it and understand kind of the risk versus reward, then we can go that route. But I always like try to strongly educate them and manage expectations with that. And so that's where you just have to, if orthobiologics aren't an option, you just have to figure out, okay, what is the best option for this patient where we can try to get them out of pain, but it's also not, like I mentioned earlier, kind of rob Peter to pay Paul in the end.
Hmm. With respect to ketorolac, 30 milligrams where you start with in terms of your dose.
If you look at some of the subacromial data, they actually use 60 milligrams. And so, based on the subacromial data, I go between 30 and 60. I have not made a definitive decision yet as to what kind of my go to is. And I have not figured out, there isn't data to tell us that like with steroid, where I'm confident that a lower dose does just as well as a higher dose. I'm not necessarily as sure of that with ketorolac, and I don't think data is really out there to tell us one way or the other. So I do go back and forth, and I'm trying to build clinical experience with that, I'm just not sure yet. But I go between 30 and 60, and I think if you look at the data, um, 60 for subacromial. For some of the larger joints, you can probably use 60. For something smaller, just from a volume standpoint, so 60 milligrams is 2 cc's. And so for something like a CMC joint, like you're just not going to get that in there without a patient hating you along with some local anesthetic. And so I'll use like 15 milligrams there. So that's where I think with ketorolac, we still have some to learn, like what is the ideal dose for different joints.
Unless I had a really bad arthritic CMC last week, and I had the ortho intern with me, so I had him apply a little traction to get around the osteophytes and stuff like that.
Yeah.
I'm joking. We probably don't want to do that because just so people know, because we're using some anesthetic as well. So trying to put 3 cc's in a CMC that has some arthritis is going to be very challenging.
I tell that to people that are with me, whether it's a resident or a fellow or students. If someone tells me that if you look at a note and like we injected, whatever, 4 cc's of fluid, whether that's to a steroid and to a local into a first CMC joint, I want to tell them, how I know for a fact you weren't in the first CMC joint? The fact that you just told me you injected 4 cc's into it, because I know for a fact you weren't in there. So I think that's where we're not going to go down this path where the imaging guidance aspect of things comes in. So I think the more of these you do, the more of these you do with imaging guidance. And I see, I mean, even 1.5 cc's into a first CMC joint can be really uncomfortable for people. So I tend to use just like 1 cc. I'll use a half cc of anesthetic, a half cc of steroid, or ketorolac. And so I think those are other things to keep in mind in this whole discussion.
Yeah, we touched on the image guidance part of it before with Adil Khan, but I think that logic also applies when we're talking about SI joint, because I think people will try to put 5 cc's in an SI joint, and I'm like, the joint doesn't hold that much volume, right? I don't know how much you use for that.
I do put 5 cc's into the syringe,
Really?
but as you kind of go up to it, I will kind of get some of the like ligamentous structures right over the top of the
Right,
joint and
right.
then drop down into the joint after that. And so I all five of that is not going into the joint, but when I do an SI joint and then you have the ligamentous structures kind of sitting right on top of the joint, as I go, I'll numb people up, I'll go down, I'll inject a little bit into the ligamentous structures right there and then go down into the joint from there. So
Gotcha.
that's why I do and I don't use 5 cc's.
Gotcha. Yeah. Thank you both. This is, I'm the novice coming into here compared to you both. So I didn't even realize there was like data on Toradol and stuff, looking at it intra-articularly. So I think this is going to be super helpful for a lot of the trainees listening to this. And that was a great breakdown, Dr. Bauer. So thank you. I did want to bring it back to PRP though. We did
Yeah.
talk about intervals for steroids as well as Toradol. Is PRP more of a one and done injection for your patients, or how do you look at the timeline for that?
Yeah, so I always go into it as, and I'll tell you, there's one pathology that I feel differently about. I always go into it and counsel patients. We're going to do this one time. We're going to give it 3 months for the healing cascade to do its thing. And so we'll do one injection. We'll reevaluate at 3 months. And generally, I think we find with orthobiologics and whether it's PRP or in the others, you have responders and non-responders. And so generally, I'll find that patients don't get much improvement at all, or they get pretty profound improvement, kind of 70, 75% or greater. For patients after that 3 month period of time, if they're sitting in the gray area in between, say they feel 40% better or 50% better, we may have a discussion of doing another one. But I think those patients, for me at least, are few and far between. So in the immediate phase afterwards, I really only plan on doing one injection. And so, say it helps them, and they come back in a year and a half or 2 years and they want to do it again, I'm okay with that. But as far as series of injections, we're say we're going to do one PRP injection a week for 3 weeks. eh, I'm not sure that the data says that multiple injections at one time is better. While there certainly are papers out there that have an injection series and patients do well from an outcome standpoint, I'm not sure that it's robust enough to where that's going to change my practice to do multiples. Now, one area, and this has been both in my experience and some of my colleagues and speaking with them, is proximal hamstring tendinopathy with one PRP injection. Generally, from clinical experience, just doesn't work. And if there's one thing there, I'm going to counsel a patient, hey, we may have to do two of these. It's going to be for proximal hamstring tendinopathy, which is it's one of my least favorite things to treat because it's so difficult. So proximal hamstring tendinopathy, and that's kind of across the board in any patient populations, but then and also patellar tendinopathy in an athletic population that doesn't get better with simple like PT and rest. I think like those two are super difficult to treat, and even with like biologics, and we have 10x and all these other things that just end up shockwave. They're just difficult to treat. So the one caveat to my single injection approach would be proximal hamstring tendinopathy. Um, but I really tried to exhaust other conservative measures for proximal hamstring before going straight to PRP because I know it'll probably take more than one just based on clinical experience. But otherwise, if you just are gonna say in general, I always just counsel we're gonna try this one time. We're gonna let the healing cascade do its thing for 3 months, and we'll reevaluate it 3 months afterwards, and then make a decision from there.
Yeah, yeah. My philosophy is the same. Is because we're going to reassess it, but again, because as you mentioned, it takes 6 to 8 weeks for it to even start working, and 12 weeks we'll see what the effect is. I I know we were coming up in an hour, and but we did promise people that we're going to do a deep dive in PRP and really hopefully educate the listener. And I think that so far we've done that. I do want to switch to baseball medicine because that's your other passion. But before that, the last thing I want to talk about PRP is augmenting
Right.
PRP. I think I'm not really familiar with any data out there looking at, when somebody has a platelet disorder, and I'm not necessarily talking about morphology, but even a volume issue. So
Right.
somebody with ITP, where you have a low platelet count, that kind of stuff. There's some data
Yep.
from Dr. Adam Ans and stuff talking about exercise, and even more stuff coming out of BFR over the last 2 years. What are your thoughts about that kind of aspect of it? Will you completely shy away from PRP with a platelet disorder? Will you use one of these tactics to augment PRP and platelet response?
Yeah. So if in the way that I do it, if they do have a platelet disorder, they have thrombocytopenia or like ITP or something like that, then I generally won't go to PRP because I just think that, to get the concentrations that you want, it's just going to be more difficult. And while you can talk about some of these augmenting things, so like you talked about like Adamans, and we have some data that exercise. So maybe a patient going out like immediately before they have one of these treatments and they exercise could increase platelet concentration. It's possible, and then BFR training and things like that. So I think that data is out there. I just don't think we have anything definitive yet, and doing that beforehand just makes the whole process a little bit more difficult. And so if I think that there's a patient out there that would actually do those things and would want to do those things, and maybe we'll talk about it. But I think that would probably need to be in more of somebody that already has they're an athlete, they would want to do those things, and maybe they have a platelet disorder, and I really feel like appropriate PRP would help them, then we would do those things. But generally, I think if we're just looking at someone with a platelet disorder, I'm not going to go down the PRP path with them because I just don't think they have enough of a chance to do well to when you bring in the out-of-pocket cost, unless they have some financial flexibility and it's something that they've read about and really, really want to do, then we will then we'll do that.
Right. Love it. So now let's talk about baseball medicine. This is the sport that we started with, and we're going to come back to it. And I'd love to specifically talk about some of the challenging diagnoses in baseball. I think people at this point have certainly heard about UCL injuries time and time again. And then the other one that is a bit challenging for people to even grasp is this thoracic outlet syndrome. I last year's AAP&R, and I took one of the TOS courses, and at that point when I started reading more about it, I was somewhat surprised that the research isn't quite or the data aren't quite clear in how to manage this. I mean, it's certain that something we've been learning about since medical school, but really it's more of an art than a science in terms of a protocol. You guys have been at the forefront. You, Dr. Wagner, have been at the forefront to kind of publish. One strategy for it is, what are your thoughts about this diagnosis? Maybe you could kind of give a brief overview, explain it, what it is, where the compression sites are, and what are the challenges with this, especially in terms of diagnosis and management.
Yeah, so this is something that I've gotten into over the last couple years, like pretty deep down, and feel like for the diagnostic blocks that we do for thoracic outlet, I would venture to guess that I probably do more of them than anyone else in the country, just because of the where we've gone down this road, and so I feel like I'm fairly educated to talk about and what I feel like drives this condition, and so I'd say traditionally for thoracic outlet, people will hear about a vascular surgeon doing a first rib removal to open up the thoracic outlet, which is basically kind of that space between the pectoralis minor on the bottom side and kind of the scalenes on the top side. You have the first rib and the clavicle in between, and you have the brachial plexus, which is running through, as well as some prominent vasculature there as well. We know that about 95% of thoracic outlet is neurogenic in origin and not vascular. And so I think there's a big gap as far as, in my opinion, it needs to be a kind of a treatment team between someone like us that can help from diagnosis with diagnostic blocks or can help with non-operative treatments if we're going to try some injection therapies first, orthopedic surgery and vascular surgery together. And so we're just we're blessed at Emory. Do I have all of those avenues? So I kind of do the non-surgical stuff. We have Eric Wagner um, on the orthopedic surgical side that can do some of these arthroscopic procedures that we're learning more about. And then Dr. Dewari is on the vascular side, and he trained with Dr. Thompson in St. Louis. He's one of the more prominent thoracic outlet surgeons on the vascular side. And so I think, and we certainly see this more in overhead athletes, because you think about an overhead throw, you kind of narrow down the thoracic outlet when you come overhead, and so repetitive overhead use will narrow down that space. And then also with the throwing motion, when you come across, you're kind of firing your internal rotators. The pec minor is one of those, and so if you get kind of chronic shortening and kind of hypertrophic changes of the pectoralis minor, that can create some compression back through that area, as opposed to up at the scalenes you don't necessarily see that as much. And so what we have found in doing a lot of these diagnostic blocks, and so we really rely on the diagnostic blocks to make the diagnosis. So very frequently EMG will be normal, imaging will be normal, and imaging can do like a CTA of the chest and look to see if there's vascular compression. You can do an MRI of the brachial plexus with arms up and arms down, and even with those dynamic things, we don't necessarily see changes on the images. And thoracic outlet is definitely kind of a dynamic syndrome for a lot of people, especially in overhead athletes, because it's that dynamic coming up overhead which creates that compression and those symptoms. And so we really rely on diagnostic blocks to make the diagnosis. And so we'll do a diagnostic block at the pec minor and also a diagnostic block at the scalenes. And we found by far that pec minor is more of the driver of this than the scalenes. And so the reason to do kind of a scalenectomy first rib resection is because the scalenes are kind of spasmed. It'll pull the first rib up and compress the thoracic outlet there and compress those neurovascular structures. But if you go in and do a scalenectomy in the first rib resection and the pec minor is not addressed, you're not removing the offending agent. And so that's where when I see some people come in and it's their second thoracic outlet workup, and the first workup that they had the scalenes and the pec minor blocked at the same time. And they said, "Yeah, I did great." And then they told me they were going to remove my first rib. And sometimes they'll go in there when they remove the first rib, they'll release the pec minor as well. But first rib resection, I mean, you're an overnight hospital stay. I mean, it's a big surgery. And so you need to stage these diagnostic blocks. And when you stage them, we found like profoundly that pec minor is more the driver of this than scalenes are in an overhead athlete population, and in this the general population as well. And so if that's the case, kind of what we've done with Eric Wagner on the surgical side is, instead of talking about like a big chop and removing your rib, is you just go in arthroscopically and release the pec minor arthroscopically, and patients generally have done well with that, and that's a small arthroscopic procedure as opposed to a big first rib removal. And so I think honestly we're really trying to change the thought process of how you approach thoracic outlet. Is that we shouldn't reflexively go to a first rib resection, because we've treated patients that have had their first rib resected by other, and the pec minor wasn't addressed. I go back in, I block the pec minor, all their symptoms go away, and we treat pec minor, and they do well. And so um, it, I just think that it needs to be more of a team-based approach between the non-surgeons, orthopedic surgeons, and vascular surgeons, to be able to appropriately take care of this, and then realize that pec minor can be a driver of this way more than I think people think. And if it is, then there's a much more minimally invasive approach from a surgical standpoint to address this than having a first rib removal. Um, but then there's also, we can try things non-surgically too. And certainly we want, if a patient comes in and we diagnose them and it's pec minor, we want them to go through a prolonged course of therapy where they're going to work on scapular retraction, scapular mechanics, stretching the pec minor. And then we can even put some Botox in the pec minor as well to try to get it to relax and get them into some therapy. And some patients do well with that. I don't think the data has borne out that it's a great outcome from a non-surgical standpoint. And a lot of these patients will go on to have surgery, but if they can go on to have surgery and have a much more minimally invasive surgery that's less risky, has less morbidity, has a faster recovery, then I think we've done had a we've greatly impacted the field. We're certainly not there yet. And at the MLB Team Physician Association meeting that we just had in December, there was a talk on thoracic outlet. And I feel like it was very much still this traditional kind of talk about having first rib resection, and so especially in a professional athlete, so say a professional baseball player has thoracic outlet type symptoms, and they are going to have surgery. I mean, the difference between return to play from a first rib resection and an arthroscopic pec minor release is huge. And so I think it's just about changing the thought and get people to think about this a little bit more closely and say, hey, we can probably have a better treatment algorithm and diagnostic algorithm for this than we currently have. And in my practice now, I feel like these thoracic outlet patients are like the happiest patients that we have, because they get here and they've seen all these other people, and then you talk with them about another way to go about this, and they've kind of had this sense of dread and doom because you're talked about first rib resection and all these things, and we say, okay, we're going to take a different approach to this and see if we can't get this better a different way, because they thought they were on the doorstep of first rib resection, and we've gotten them better other ways. And so I really think that from a treatment paradigm standpoint, that we can make a big difference with this. But certainly it is very much a niche, and it's something that a lot of people don't see a lot of, but it's something I feel pretty strongly about. And so I think that we're just a better understanding of this process, and I think even more so just the pec minor being the driver of a lot of these things. And so if we take this approach, I think we can avoid some big surgeries for people.
Yeah, I think the first time I've seen TOS in an athlete, just on the news being major, was Markel Fultz when he was on the Sixers, NBA player,
Yeah.
drafted first overall, now in the Orlando Magic. And I remember, when he first couldn't play, the fans and everyone was like, what's actually going on here? And the medical staff wouldn't outright come out and say anything. And it just goes to show kind of what you're talking about. I mean, these things can be difficult to diagnose, like exactly what's going on. Is it neurogenic, vascular, etc.? Finally, the news came out, and I was probably a third year in medical school, and I remember everyone as a DO was like, "Oh, it's thoracic outlet syndrome. You just send him to a DO, right?" I mean, because we learn it from a
Right.
myofascial standpoint or whatever.
Yeah.
But it's funny because just as you broke it down, I mean, this is something that's more complex than we just learned in medical school. So I just wanted to throw that comment in there for those who wanted to relate it to a specific athlete, at least. Markel Fultz, at least, is one that I remember pretty clearly that they talked about.
Yeah. Yeah, and more recently in baseball, Steven Strasburg's had surgery for it. Matt
Okay.
Harvey had surgery for it. So there have been some baseball players as well. And the surgery has still traditionally been the first rib resection with a couple
Okay.
prominent surgeons throughout the country. And I'm not sure. that's where, I'm not sure, was that necessary, or could we have done these staged blocks and kind of figure out the driver a little bit more and done a less invasive surgery? And so that would be, I'd be very happy if within kind of the baseball community, I could play a role in changing that thought process, because we certainly see TOS more in the overhead athlete community than we see in the general population.
Yeah, and the other point I think is worth noting, you talked about the non-surgical outcomes, at least from the standpoint of rehab. And we talked a lot about how not all PRP is created equal. And I often tell my patients when they go to physical therapy, and not even TOS, something as complex, but something as simple as knee osteoarthritis or glute med tendinopathy, and they come back, well, therapy didn't work. And tell them, not all physical therapy, not all rehab is created equal too. So
Right.
something as nuanced and complex as this, you need a qualified professional who has a deep understanding of the fascial system, throwing mechanics, all that kind of stuff, to address the right things. This is not going to be your standard periscapular training, band pull aparts, et cetera, et cetera, et cetera. And so I think you also need to identify a network of somebody who really understands TOS and what type of strategies seem to work and not
Yeah.
work. And that's also super important.
Yeah, I think for just our field that we're in general, you need to establish a network of well-trusted physical therapists, because, like you said, all physical therapy is not created equal. Just like, they're good doctors and bad doctors. They're good doctors. I mean, they're good physical therapists and bad physical therapists, and just giving them a physical therapy um, prescription. I know this is something that Dr. Malenga felt very strongly about as well, is you can't just give them a physical therapy prescription and say, oh, here's some locations, go do therapy, and they come back and tell you it didn't work. And you're like, okay, therapy didn't work. You got to ask them what they were doing, what they were focusing on, and they're not just gonna go in and have some modalities and then have someone go tell them to do exercises in the corner. I think that is another part of the health system that is difficult, because a lot of the best physical therapists are going to these kind of out of network one-on-one situations, where I think that really is the best situation, where a patient gets an hour of one-on-one time with a therapist, where they get a thorough exam and they really get work with one-on-one. But there are lots of patients that can't afford that at all, and so they'll go to one of these big box places, and some of the big box places will have a great therapist there and does a good job and can work with three patients at the same time. But some it's a therapist right out of school, and they haven't really gotten their feet wet yet, and they have four patients at the same time, and it's just hard for a patient to get better in that situation. And so I think we really need to do a good job of developing a network, both of therapists that may be more in that out of network model that do one-on-one, but also therapists that still go through in network, that you trust in, and that it's going to do a good job of taking care of the patients and being able to refer patients appropriately, and know that they're going to get somewhere that they're going to have good treatment. And I also think there's, we've another person within the PM&R world has started a company called Limber Health, which is a home-based physical therapy through an app that they follow videos, and some of these other places online, like the prehab guys, are online, and patients can pay. It's a couple $100s, but it may end up being cheaper than their copay going into therapy, where they can do these home programs and have easy, simple videos to follow, and I think patients could do well with that too, because it may lead to more increased compliance. I think just giving them a sheet with exercises on it is difficult, and some people don't know how to follow that. But if they have a regimented program where they can watch the videos and do the exercises, I know patients are there's going to be probably a groundswell of patients doing those things at home. And so I think companies like Limber, or some of the online programs, are play an important role in this process too, and give us a better option of how to treat people, and maybe increase compliance with physical therapy.
Yeah, but on that note, also critical for providers to understand exercise modification and prescription, right? We've had many guests come on here talk about exercise, physical therapists, many of the people that you're kind of referring to. Yeah, the prehab guys are amazing on Instagram. They've got their own app and all the stuff too. But yeah, I think one of the point that I make with my students is when somebody comes back is, they did physical therapy, it's working or not working. I ask my students, did you ask what they did? I want to know specifically. Another loose red flag for me is when I go to the patient and I ask them, and they're like, yeah, I've been doing physical therapy for 3 months. And I ask them, hey, what did you do? And they cannot tell me, right? So that also tells me that maybe they're not being educated on how to do the exercises and why they're being done. I think that that's also a critical standpoint. But if we don't understand the exercises, then we can't assess whether or not that's a good exercise. And again, I had my time with Dr. Malenga, and he was so incredibly passionate about this, and so I want to make that point as well.
Yeah, for sure.
So I want to pivot here a little bit, talking about your role as a team physician. Obviously a lot of pre-meds or medical students who are interested in sports med aspire one day to become a team physician for professional sports. And I think even the lay population have certain expectations or thoughts about what a team physician does. Do you mind kind of just going through your roles, responsibilities throughout the year, maybe season, off season, for the Braves or even for Emory?
Yeah. So I'm definitely more of like, assistant team physician on the Brave side. And so you'll get calls from time to time with things they know, but I'm not like the head guy, so I'm not the one they're calling all the time um for everything. And so from a team physician role, you certainly have your head team physician and then your assistant team physicians, and head team physician will get called more on a daily basis, where the assistant team docs, like, we're there for game coverage, and if one of the other docs is out of town, we can cover some of the day-to-day stuff. And so with the Braves, it's more like that, and certainly there's more volume and more need on like the professional side, and so sometimes I will get calls for that. Now I'm also the head team doc for the Hawks G League team, which is a college park Skyhawks, so like NBA minor league team. And so that you there's more that you have to do. You have to be there to cover games. You're the one that manages needs, or they talk about like medications are needed for certain players. You schedule all the preseason physicals and things like that. There's just much more that goes into it, but you also get to be the point of contact. You know everything that's going on with the team. You're making the decisions. It's nice to be the head doc, to be able to make those decisions kind of on your own. So that's helpful. And then I'm also one of the main docs for Georgia Tech's baseball team, and so that's more on the kind of the high level collegiate side. And again, that's just working with our other team doc to you know manage player health, and we have to, there has to be good communication to figure out, what do we want to do for this player from a treatment standpoint, and be on the same page. And so that's where we're kind of, I work hand in hand with another doc, and we kind of make the decisions together for those players. And so I have a different, for like the three higher level teams that I work for, or work with. I don't necessarily work for them. It's just a different dynamic, where I'm kind of like an assistant team doc and don't do as much of the day to day. I'm more of a head team doc along with someone else, where we kind of do things jointly, me and an orthopedic surgeon. And then where on the Skyhawk side, kind of on my own. And um and and so there's that aspect of it. But then I know that, maybe we want to have the discussion beyond just the role of the team physician being just managing player health, and having a lot of good open communication with the head athletic trainer for the team, and then being there for game coverage. So people think team doc being there for game coverage, but then I know there's also their discussion of return to play, and managing team expectations and coach expectations, player expectation, and combining that with, okay, what from a medical standpoint do we think is best for that player, that we can get them back appropriately, but also in the most time efficient manner. And that certainly is an art, and is scary to an extent, because you don't want to make the wrong choice for a number of reasons.
Yeah, no, I would love to delve into that. And I can only imagine there's so many cooks in the kitchen when it comes to when a player gets injured, right? I mean, I remember as an athlete growing up, and this probably for most high schoolers, if you sprain an ankle and the doctor says, hey, you're going to be out for about 2 months, you're like, there's no way. I have a big playoff game coming up and I'm going to get back in there. And then,
Yeah.
obviously with injuries in sports science kind of advancing, everyone kind of knows about the Tua story about coming back, repeated head injuries. And obviously there's going to be implications from where they are in the season. Is it off season? Are they closer? How big of a game is it? Maybe the role of the player on the team. What are those discussions like that you have, and how do you view it? Or is the team physician looking strictly at it from a medical point of view, or do they also have to take into context kind of all those other things I just mentioned?
Yeah, I think in an ideal world, you could just look at it from a medical point of view, but I would say that decisions in certain situations with athletes are you know, or you try to speed up the process a little bit with especially with high level athletes where, especially in team sports to try to get them back. And one thing I'll say is that in my experience, you don't necessarily have discussions with the coaching staff or management as much. That does happen in some situations, but it definitely is more as you're going through the athletic trainer. They're kind of the liaison to the organization, and you all you can do is just try to provide insight from a medical standpoint as best you can and explain that if you go based on the literature. So say like for a grade 2 hamstring strain, we're looking at grade 2 hamstring strain. Do we you know how fast we're going to be able to get them back. And then we have a discussion. Okay, do you do an orthobiologic for this injury? And maybe if you look at some of the data, that it's very mixed in literature. We're talking about PRP for hamstring muscle injuries, and then we come into the to use platelet poor plasma. And if we do these things, maybe we can get them back in 21 days as opposed to 34. And there's one paper that says that if we can get them back 2 weeks sooner, that's a big deal. And so I think that with the higher level athletes, there's probably more of a push to get things back more rapidly because maybe there's a little bit of pressure from the organization, even though they're not telling you that themselves. But you also see things in the literature currently about players that after the fact felt like they were pushed back too fast, and they felt like that led to further injury, and then you get sued, and I think that's also something that we have to think about too. I think being a team doc for a high level team, especially the one that's making the primary decisions, I think it's in the short term, you're looking at trying to get the player back. What's the fastest way we can get them back? But you always have to keep in the back of your mind, like make sure these decisions aren't being made with possibly some long term expense to it, because that's going to come back on you and come back hard, whether you're well respected or not. And so I think just having knowing all of those factors, I think it's can be a slippery slope and just something where, yeah, it seems glamorous to be a head team doc, but I think there's a lot of risk that goes into it as well. And you have to really be able to manage the expectations of the player and the coaching staff. And then certainly as you get into professional sports, there's the issue of agents, and agents are in their ear and pushing them in certain directions as well too. And that's one thing on the college side. You're not with NIL. Maybe we're going to start to deal with that a little bit more on the college side. And I know that, we're starting to see that a little bit where there's more advisors and agents kind of getting their nose into things. But definitely on the pro sports side, the agents play a big role in decision making with the players as well. And it's just an interesting dynamic and very different from clinical day to day medicine because it's just between you and the patient. Where in sports medicine on the high level side, that there's a lot of other factors involved, and it's not as simple as, okay, I think this is the most appropriate treatment. We're going to rehab you. I think that this is the amount of time it's going to take, but it could take longer. Whereas sometimes in the sports side, like they want to know, like, how long is this going to take? Do we need to pick up another player? Do we need to put this person on the IL for this period of time or that period of time? So it's a very dynamic process, and it definitely has been a learning experience for me. I mean, you learn, like, especially on the pro sports side, there are certain things you do not say to players. You don't bring it up. You have to learn, because you say something to them, and even if it's you're just making conversation, that thing gets to their agent and it becomes a big deal. And you have to learn the dynamics, and it can be a slippery slope, and it's been a learning process for me for sure. And I feel like I put my foot in my mouth a few times already, and they'll let you know if you do that. And so it can be an uncomfortable situation sometimes. But so there's pros and cons to taking care of pro sports teams. Like, it's something I've always wanted to do, and I'm like more than happy that I'm able to do it, but you have to just be careful with the things that you say and do.
Yeah, absolutely. Thanks for clarifying that. I mean, definitely more complex than what the eye can see, from
Yeah,
our
I probably
standpoint, our vantage
rambled a little
point.
bit there. I felt like I was
No, that was
rambling.
great.
So, but I just was trying to think things as we went along, and it almost sometimes becomes less about medicine and more about managing personalities and expectations.
No, absolutely. And I think that's important for especially the trainees that might be listening to this who really are aspiring to be team docs. I mean, I think you're really giving them a different perspective to look at that they might not be able to see through their training. And then also for the general population. I mean, I know a lot of people go through YouTube and they say, why is the medical staff acting like this? Or why is this player not coming back? I think that gives a little bit more perspective to them as well in terms of
Yeah,
the decision making and how complex it actually is,
right. Well,
situation to situation. So,
one thing I can say is that, especially with like the Tua situation that I found frustrating as they're talking about like, oh, the docs like did him wrong and sent him back out there because the team really wanted him to, that really like pushed them to get him back out there. And like, I don't think that that's the case at all. I don't think any of these head team docs, like, no one is going to like take a significant like know that it's a significant risk for the player and send them back out there. Like they're gonna feel comfortable with sending the player back out. Like we all understand like the gravity of the situation if we were to do something like that. And I guarantee you none of the docs were like, oh, he's not ready, but let's get him back out there because the team really needs him. Like they're definitely, I know that none of these medical staffs are doing that, and that's kind of the frustrating part is they think that there's some like collusion between the team and the league and all this stuff and the medical staff, and that's just not the case. And so if anything can be cleared up, I know that I know that's not the case. We still have kind of the Hippocratic oath that we're bound by, and so we're not gonna um, definitely not going to a situation like that, especially something like Tua, send him back out there if they didn't feel comfortable that he was ready to. And I think it just ended up being an unfortunate situation.
yeah, for sure. I did want to ask you, since you're a baseball guy, baseball season's kind of underway right now. Some new changes to the rules, so I believe that you can no longer changes in shift changes,
Yeah,
and then there's a pitching clock as well. So we're seeing an
right.
increase in runs as of now, at least in spring training. How do you think that's going to affect injury rate from a pitching standpoint? Do you think we're still going to be using the pitch count as the marker for when the pitcher's going to be done and you bring in the bullpen, or how do you view that?
Yeah, I don't think the pitch count will affect injury rates. I mean, maybe I'm proven wrong, but I don't think it will. I think it's still about managing volume and those sorts of things. And so we know from an injury risk standpoint, we're going to see more injuries as velocity gets higher. We know increased throwing velocity is an injury risk. We're seeing faster and faster velocities as players are training differently, and so we know we're going to see more injuries. And so it's about managing volume and intensity over the course of the year as opposed to the pitch clock being a little bit having to throw in the pitch more rapidly. I don't think in the end that that's going to play a huge role in injury risk. What could play a role in injury risk, though, is the bigger bases. And so the fact they have bigger bases this year. And so with the base bigger, so say runner is, catcher's trying to bobble to third strike and is trying to throw the runner out at first and throws it into, kind of into the way where the runner is running before the first baseman. If he had to come off to the side and keep his foot on the bag, his foot would still be on the bag and the player could like step on it and injure his ankle. Whereas at the bigger bag, he has a little bit more room to move around. And then also with players sliding head first into the bag, they have more room to work as far as where they can grab it and not be in the same line as the other players. So I think that if we look at it down the road, that the bigger bases will probably decrease injuries to, maybe not to a huge standpoint, but I think it definitely is better for injuries than the with the bigger bases and the smaller ones.
Yeah, I forgot about that rule. Yeah.
Yeah, that'll be interesting to see. I, for one, am a fan of the timed pitch clock. As somebody who's, I know I'm among two diehard baseball fans here, but somebody who had previously found it challenging to watch a whole game.
Yeah.
For some of
Well,
those
games are
reasons, I'm
definitely
excited about that.
faster. Yeah,
Yeah,
games are definitely
yeah,
faster in spring training. One thing that someone brought up that I hadn't really thought about is that our team's going to like it because if games are shorter and they cut off beer and food sales in the seventh inning, like you don't have as
ooh,
many people like maybe not food sales but beer sales. You don't have people buying you don't have as much time to buy stuff up. So maybe profits for concessions are going to go down. So that's something to look at. But just the little things. But it certainly will be nice. So like when I cover a Skyhawks game, usually those basketball games are like dead on, like right at 2 hours mostly. Where with a baseball game and football game more so, there's definitely a variation in baseball with extra innings, and
Hmm.
if it's a,
Hmm.
sometimes you'll have long. There's definitely not as much of a, you can't say definitively like this is going to be the time that I'll be done. So it'll definitely help with that as far as speeding things up and not having my wife mad at me as much.
Speaking of innings, I don't know if you guys saw this. I forget, it was a college baseball game where they were pretty much wrapped up and the umpires just walked off because I think that the team was losing and there was no chance to come back. Did you guys see this? You know what I'm talking about?
No.
Okay, I'm gonna have to find it. I'm not gonna get the details right, so I'm gonna find it and see if we can put a YouTube video of it. Darsh, go ahead. You were gonna say something.
No, I was just gonna say we're down. I think the baseball games, based off the data, are down 22 minutes so far in spring training, is what they found. So, an improvement from at least for fans like Altimash who can't hang in there.
It's
Right.
too much for me. Well, Dr. Bowers, this has been informative and super educational. Selfishly, I've learned a lot about orthobiologics, sports medicine. I want to thank you for your time. I think that, as you mentioned, I think you're probably selling yourself a little short. I think you're definitely one of the leaders in the field for both orthobiologics and baseball medicine. And I've found myself annoying you quite a bit since I've become an attending. So hopefully you won't mind me continuing doing that as I get these challenging cases and just pick your brain a little bit. I'd love to ask you
No.
about what is it about the future of biologics, sports medicine, really, nutrition stuff. I mean, you have so many areas of expertise. What are you really excited about over the next couple of years, and really all those things?
Um, excited from, so there are a couple different things, and I don't know if it's necessarily excitement or what I'm looking forward to. And so let's take it one way with orthobiologics and throwing athletes. So we combine kind of the two of my interests, and we didn't get a lot into to ultrasound, which obviously a lot of us have big interest in too. But orthobiologics and throwing injuries, we have a review paper coming out in that fairly soon. It's been accepted for publication. I just gave a talk on it at IOF, and really, as far as orthobiologics and throwing athletes, we really only have significant data for PRP for UCL injuries, and we didn't get in that today, and we could have. And if anyone wants my recorded talk that I gave on that, it was brief. It's only like a 12-minute talk, and I can at least I can send that to anybody if they want to reach out to me. Um, Outside of that, we don't have a lot of data on orthobiologics for throwing athletes, and I think it's hard to extrapolate other orthobiologic data to throwing athletes because of the unique stresses that are placed on the throwing arm, so the shoulder and the elbow. So I think over the next, and I really at my talk at IOF tried to make it kind of a call to arms to an extent to really, and I know people are out there that are treating throwing athletes with orthobiologics, and maybe they haven't published, and I really just call them to try to publish anything they can, even if it's just case studies. It's helpful for throwing shoulders and throwing elbows other than UCL injuries, and even like obliques that we see a lot in baseball players. And so I'm hoping that we start to see more data specific to throwing athletes, because it's hard to say, oh, in the general population, we've treated this partial rotator cuff tear with PRP. It's hard to extrapolate that to a throwing athlete again based on the unique kind of demands placed on a throwing shoulder and a throwing elbow. So, I'm looking forward to seeing more data on orthobiologics specific to throwing athletes here over the course of the next several years. And I think as we talked a lot about PRP today, I think continuing to grow our understanding of, and we'll figure out kind of their different platelet preparations that are better for certain pathology, where we talked about, like, at this point I'm still using leukocyte poor for pretty much all pathologies right now, and I feel comfortable doing that based on the literature. But will we learn something else going down the line? So certainly that, and then just something simple is starting to see, what we've been preaching since 2015 when PRLA came out. Um, that that studies are talking about platelet concentrations and what are the platelet concentrations and leukocyte rich or leukocyte poor that they're injecting, and not just calling everything that's blood that's spun down once or twice PRP. I think the literature starting to fully reflect that, where we can have more of a nuanced discussion where it's not just, oh, they use PRP. And so I think just continuing to have more nuanced discussions about orthobiologics and in sports medicine. I mean, I think with all of us being in PM&R, and I'm sure that y'all, I don't know if you have heard about like the NBA thing of kind of removing, discussion of kind of removing PM&R as one of the specialties that can take care of an NBA team. I think um, I'm not excited about it, but I'm interested to see where this goes with sports medicine because I think as PM&R, we're a little bit in no man's land where we're kind of, we have we're kind of stuck between the MSK ortho side and the primary care side, and I think that we all do our board certification in primary care sports medicine, and that's what we do when we take care of teams. But I think we're kind of the easy specialty to kind of odd man out if people want to, and I just I'm really hoping that this doesn't become somewhat like of a trend across other leagues, and I think what I've seen to this point, it's not going to, and I just wish that there weren't like politics and personalities and stuff involved, but unfortunately there are. So not that I'm excited about it from an overall sports medicine standpoint. I think that they were kind of close at a crossroads and a big turning point of what sports medicine looks like for a PM&R physician based on the discussion that some of these leagues make. And I think that, we certainly have lots to offer, and hopefully it's not something that impacts in the future a med student's decision of whether to go into PM&R to pursue sports medicine versus another specialty based on what the decisions that some of these leagues are making. And so I'll be interested to see where that goes, and hopefully this is just kind of a bump in the road, and these organizations will lobby for us, whether it's AAPM&R, AMSSM, ACSM, all these other organizations. Hopefully, this doesn't become something that becomes a problem. Not to be a Debbie Downer at the end of this, but I think when I think about being a sports medicine physiatrist in kind of and where things are right now, I think that's what I'm most interested in to hopefully be a voice in that that we of what we bring to the table and can fill the role of primary care sports medicine physician just as well as other specialties can. I think that is something I'm more than passionate about being a voice of.
Yeah, yeah. No, it's definitely frustrating. But at the same time, there's exciting things on the horizon too, and that's just medicine and healthcare for you. And it's going to be an ever evolving discussion and trends that we hope to fight to we hope to live to fight another day. Essentially. Well, Dr. Bowers, I just want to thank you so much. Definitely from my perspective too. Again, being the novice in here, I learned a lot. I've got notes. Definitely more things for me to look into. But where can our audience find you? I know on social media you post about your life and world within the sports world. So
Yeah, and I'm not as vocal on social media. I mean, as I used to be really passionate about kind of misinformation online, and I'm
sure.
just not as worked up as I used to be, as I rapidly approach 40 years old. Um, I'm less than half a year away from the big 40, so maybe in my old age getting I'm not getting as worked up. I still get worked up fairly easily though. Um, so yeah, but I still try to put out informational stuff on orthobiologics and ultrasound and throwing athletes. So anyone can feel free to email me. It's just robert.bowers@emory.edu, my first dot last name at emory.edu, and I'm happy to respond to emails. Just um, you know don't send me a bunch of spam or sign me up for any like email lists or anything like that. Um, and then my Twitter and Instagram handles are I wish they're they're very old, and I use my nickname from what kids used to call me in little league, and sometimes I think, is this really the best thing that I need to be using for like my professional account? I just never changed it, but it is what it is. So it's on Twitter, it's just at the Dr. Dr. the Dr. Robo, Robo. So people called me Robo when I was growing up, and I thought it was funny 12 years ago when I started Twitter right after I got my PhD, that I would do that, and it's just never changed. So maybe it's a
I think that's a
unique
great
name, but
handle, honestly.
yeah, maybe it's a unique name that people remember me by. So on Twitter at the Dr. Robo, and at Instagram it's similar. It's just at the _Dr. Dr. Robo, and and I try to put stuff there. I'm probably a little bit more active on Twitter nowadays than I am on Instagram. Instagram's more just posting. I don't post a lot of posts anymore. It's more of just kind of story stuff, but it usually is an extension of what's on Twitter. So I'm always happy to interact on Twitter. And we were, I won't belabor this, but I was just having a discussion with two other docs actually just yesterday, or on Friday, talking about a patient, and we had a very spirited discussion on Twitter recently about hydrodilation for frozen shoulder. And so I was talking to two docs in that discussion, and literally a discussion on Twitter changed the way that I practice based on hydrodilation for frozen shoulder. And over the last few weeks, I've been doing it differently and actually feel like it's made a difference. And so Twitter, while it can be a terrible place, it also can be like a very high yield place to learn new techniques and it to actually change your practice. And so I think if you get into the right situations on Twitter, and there are lots of like well-known like worldwide experts on Twitter that post educational content that you can get for free that can change your practice. And so I just encourage people to kind of get involved in social media and get involved in discussions, and you can learn new things very easily. It's like having like a worldwide leader conference at your fingertips every day. It's just about finding the right information.
As an active follower of that discussion, I do have to say that was it's good because there was a lot of literature presented in there, and
Right.
so it was good to kind of just curate that information, follow that. So that was good discussion for sure.
Yeah, no, I totally tell trainees all the time. A lot of them are so afraid of going on Twitter because of just what you mentioned, like the politics, med Twitter, all that. But if you stray away from
Yeah.
that, I think Twitter's a gold mine for anything and anything that you want to learn. Like you said, there's so many experts that are on that platform rather than on Instagram or TikTok and whatever else. So
Right.
absolutely.
LinkedIn can be helpful too from that standpoint as far as learning things. LinkedIn, I find things on LinkedIn too, but things are a little bit cumbersome to find maybe sometimes on LinkedIn, but Twitter's a little bit easier to follow. But those two are where I find that, I'll learn more than elsewhere.
Cool. And I love Robo. When Altamash told me that, hey, we got Dr. Robbie Bowers coming on the podcast, I initially was like, oh, Robo. Okay, great. So it
Yeah,
definitely
right. There you
sticks.
go. Yeah.
Uh,
Yeah. Cool.
well, hey, we just want to wrap this up with one last question. As the audience kind of knows about this, it's funny because we never asked you directly anything about the inefficiencies of healthcare, but yet in every episode, something or the other kind of pops up, whether it's about insurance, whether it's cost, whether it's the nuance discussions that we have to have. And, we obviously don't live in a perfect world, but the last question that we ask everyone is how do we add the health back into healthcare?
And I think this is a tough question because I think it's going to be hard. I think just because of the machine that the healthcare system is, it's going to be hard for us to make like a system-wide change. And so the way that I approach it is you have to take it from kind of like a grassroots level and build it yourself and try to make that change from your practice. And maybe it rubs off on others and maybe it doesn't. But I think within your small bubble and within your own practice and your realm, you can try to make the changes that you would like to see within healthcare. And so you can talk about like those four pillars. And so whether that, talking about exercise with patients and nutrition with patients and sleep and stress management and those things, while we don't have a ton of time, you can at least start to try to touch on it and you can build on those things at subsequent appointments. And I think it's just bringing that aspect. It's not just about treating their knee arthritis or their tennis elbow. It's about talking to them about these other, especially if you see red flags. It's about talking with them about these other things, and the discussion can go. You can make a lot of inroads. And so the way that I approach it is trying to take that well-rounded approach and talking about these other things. So exercise and nutrition and sleep and so I mean all those things can make the treatments that we're talking about for your musculoskeletal conditions so much more successful if you build in some of those other aspects. It's not just about coming in and getting a cortisone injection every 3 months and then going back out there. It's trying to make actionable changes elsewhere. And so if you can take it from a grassroots level within your own clinic and your own practice, and maybe that starts to rub off on other people, or if not, at least you have that within your practice, or you feel like you're really making a difference for these patients as opposed to just helping with their injuries or the musculoskeletal complaints.
Yeah, love it. Grateful for your time, Dr. Bowers. Thank you.
Thanks, guys.
Thank you for tuning in to another episode of Medicine Redefined. And a special thanks to our team for the production of this podcast. Without you, this would not be possible. Shout out to Ethan Ju, Iman Bashiri, and Haritha Yapuri for all the work that you guys do. Now, before you sign off, please remember the important disclaimer that everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, nor should it be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. However, if you enjoy the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. And until next time, thank you for listening.